Good morning and good evening, ladies and gentlemen. I'm Dr. He from Beijing Anzhen Hospital, Department of Pediatric Cardiology. So thanks for giving me this opportunity to join in this wonderful conference and sharing the topic, pregnancy and delivery in pulmonary hypertension. As defined by the World Symposium on Pulmonary Hypertension in 2018, pulmonary hypertension is a mean pulmonary artery pressure greater than 20 millimeter mercury measured during resting heart catheterization, and PAH is precapillary pulmonary hypertension, characterized by mean pulmonary artery pressure greater than 20 millimeter mercury and pulmonary vascular resistance greater than 3 units, and pulmonary artery wedge pressure less than 15 millimeter mercury, and in the absence of significant left heart disease and lung disease. So the general purpose of clinical classification of PH is to characterize clinical conditions associated with PH based on similar pathological mechanism, clinical presentation, hemodynamics, and therapeutic management. A comprehensive and simplified version of the clinical classification of PH in children and adults is presented in this table. And in most PH registries, IPH, which is idiopathic PH, was the most common type, followed by PH associated with connective tissue disease, congenital heart disease, and portal hypertension. So PH causes a reduction in pulmonary compliance and an increase in the pulmonary vascular resistance. Normal physiological changes during pregnancy, such as an increase in plasma volume, heart rate, stroke volume, cardiac output, hypercoagulability, and the inferior vena cava compression by the uterus, as well as the decrease in blood pressure and the systematic vascular resistance are not well tolerated in patients with PH and can result in right ventricular failure. And the risk assessments in the patients with PH and in all women with cardiac disease is recommended. And the World Health Organization function class is a helpful tool in guiding the prognosis of patients with PH, not only at the time of diagnosis, but also during the follow-up. However, this tool has not been validated among the pregnant women. So the disease-specific risk class should be assessed using the modified World Health Organization classification. The modified WHO classification is currently the most accurate system of risk assessment. So in this modified WHO classification, which categorizes patients with PH as class 4. So the patients with PH is categorized as modified WHO class 4, which means extremely high risk of maternal mortality and severe morbidity. And the maternal cardiac event rate was 40 to 100%. And the pregnancy is indicated in these patients. And if pregnancy occurs, termination should be discussed. And the caring during pregnancy should in the expert center for pregnancy and cardiac disease. And the minimal follow-up visits during the pregnancy was monthly. And the location of delivery should in the expert center for pregnancy and cardiac disease. So this is the guidelines for the measurement of cardiovascular disease during the pregnancy, which indicates pregnancy is not recommended in patients with PAH. And in the PAH associated with congenital heart disease, Eisenmenger's patients require special consideration, which includes additional complications of cyanosis and right-to-left shunting and paradoxical embolism. And the maternal mortality in this cancer of patients is very high. It's about 20 to 50%. And the termination of pregnancy should be discussed because the termination also carries a risk. And the detailed delivery plan, including the optimal mode and timing of delivery, should be decided by the pregnancy heart team. And the regional anesthesia is usually favored over general anesthesia. So let's talk about the PAH target therapy during the pregnancy. PAH in the WHO function class 4 or have evidence of severe right ventricle impairment, parenteral prostaglandins are recommended. And in selected patients with more preserved RV function who are in WHO function class 3, inhaled prostaglandins may be considered, and the PDE5 inhibitors may be considered in patients in WHO function class 1 or 2 and who have normal right ventricle function. And the most published experience is with the sildenafil. And the parenteral prostaglandins can be combined with the oral PDE5 inhibitors in pregnancy. And for patients meeting the strict criteria for vasodilator responsive PAH who are not in WHO function class 4 and who do not have RV dysfunction, CCB therapy may be continued in pregnancy with close follow-up for deteriorations. And endothelin receptor blockers and soluble glutathione selective stimulator, which is Rosegua, are pregnancy category X and should not be used in the pregnancy. So delivery is a time of greater risk for morbidity for patients with PAH. And the indicators for high risk for decompensation include severe right heart dysfunction, severe PH, Eisenmenger syndrome, and acute heart failure. And delivery is generally completed in consultation with a multidisciplinary team, including PAH specialists in pulmonary, cardiology, maternal fetal medicine, and cardia, and obstetric anesthesiology, and the nursing team, and so on. So this is an early study from 1978 to 1996 from Switzerland. You can see these numbers are pretty scary, and the maternal mortality during pregnancy was 36% for Eisenmenger syndrome, and 30% for primary PAH, and 56% for associated PAH. And this is almost 30 years ago, but before we had inhaled or intravenous ipraprostone. And this paper is from more recently published from France in 2005. In 15 cases in one center in France, 2 patients died before delivery and at 12 and 23 weeks of gestation, and 3 patients died after give birth. This is a systemic review of all public reports from 1997 to 2007. 33 patients were included, including 29 IPH patients, 29 PH associated with congenital heart disease, and other PH of 5 patients. We can see the reduced mortality over the years, but still prohibitively high. And 78% of the dies in first postpartum months, and most of them have no targeted drugs treatment. A registry from Europe included 151 patients from 2008 and 2014. The results showed that the congenital heart disease associated pH was smaller than other reports, and in more than 75% of patients, the diagnosis of pH was made before the pregnancy, which is better than before. And the maternal deaths, 5 patients died within 1 week after delivery, and 2 of 78 patients died within 6 months after delivery. So this study found RVSP, which is the right ventricular systolic pressure estimated by echocardiogram, greater than 70 is closely related to maternal mortality, heart failure, and low birth weight. And the highest mortality was found in IPH patients. This is a more recent published single-center retrospective from China, included 59 pregnant with PH and divided into mild PH, moderate PH, and severe PH groups. The incidence of pregnancy-related complications in this severe PH group was significantly higher than those in the mild and moderate PH groups. And 5 patients died in this study, and the mortality rate was 8.5%. This is a retrospective study from Beijing, from China, and we found the congenital heart disease associated PH patients accounted for was the majority. So this is a retrospective study from Beijing Anzhen Hospital, including all hospitalized pregnant women from 2010 and 2019. We found that the patients with congenital heart disease had longer hospital stay, higher cost, and higher mortality, and the incidence of cesarean section, premature delivery, and low birth weight infants, congenital heart disease in offspring were higher in patients with congenital heart disease. And this retrospective study, this is a retrospective study. I'm sorry, this is a recent published multi-center study from China, and it's from 1993 to 2019. A total of 2,220 pregnancies in women with congenital heart disease from 7 institutions were included, and the mean maternal age was 28 years. And we could find the most of the patients was with shunt lesions, and this study found the patients with moderate to severe PH had higher rate of adverse maternal events, and adverse maternal events remained high despite the improvements in outcomes in the patients. This is a retrospective study from Beijing Anzhen Hospital from our center, including all the hospitalized pregnant women from 2010 and 2019. And this study included 93 pregnant women with PH and congenital heart disease, and 32% of the patients with Eisenmenger syndrome, and is much higher than the death reported in Europe. Most patients had late hospitalization, and on admission, 1/2 were WHO function class 3 or 4, and cyanosis was found in the 32% of the patients. And I'm sorry. And 6 patients died, and 5 of them were Eisenmenger syndrome. So the outcome of pregnancy in patients with Eisenmenger syndrome was generally improved. And finally, I want to share a tough case we confronted recently. So the story began with a talk at WeChat in 2020 September. A 37-year-old woman insists on continuing pregnancy after accidentally pregnancy despite being informed high risk. So the patient insisted on pregnancy because A, she had a history of the PCOS, so it's hard to naturally conception for her, and B, she had a strong willing to have a baby of her, and 3, she thought this accidentally pregnancy was a gift for her, and so on. However, the reason for the suggestion of termination from the doctors only because the patient was diagnosed with congenital heart disease and pulmonary arterial hypertension, and she also is a BMPR2 mutation carrier, which implies poor prognosis. So let's review her past history. The patient was hospitalized in our hospital for fatigue in 2021 September, and the echocardiography showed about 5 millimeter VSD and normal right and left ventricle dimension and normal left ventricle systolic function. And the blood test showed the patient had normal cardiac function with normal level of BNP and NT-proBNP level. So we then performed right heart catheterization on the patient and found the pulmonary artery pressure was elevated and with the mean pulmonary artery pressure 36 millimeter mercury. And we think that the VSD can't explain her elevated pulmonary artery pressure, so the patient received the whole exome sequencing and found the BMPR2 mutation and is pathogenic. So the final diagnosis was pulmonary arterial hypertension, congenital heart disease, ventricle septic defects, and BMPR2 mutation carrier. And the patient was in WHO function class 2 at that time. After that, the patient received ambrisentan and sildenafil and stayed in the stable and good clinical condition. However, the patient withdrew ambrisentan when found pregnant. And the patient was admitted to the obstetric and gynecology departments in our hospital at 26 weeks of gestation in February 2023, and a multidisciplinary consultation was conducted for the patient. So we could find as the time goes by, the BNP and NT-proBNP level elevated, and echocardiogram showed the patient's right ventricle dimension increased with the gradually increasement in the systolic pulmonary artery pressure. And at the 31 weeks of gestation, we described the treprostinil to the patient. And 4 days after that, we think is the time for her to receive the cesarean section. And during the surgery, the catheter monitoring is in the table. We can see it's very high pulmonary artery pressure. And during the procedure, we used lots of vasoactive drugs to maintain her artery pressure. So after the delivery, the patient was transferred into the ICU. We could see after the delivery, the patient experienced gradually increasement pulmonary artery pressure, and we increased the dose of the vasoactive drugs correspondingly. And at day 4, the patient had relatively stable hemodynamic and back to the OB ward. And at day 6 after the delivery, we withdrew the vasoactive drugs gradually. And at day 15 after delivery, the patient discharged from the hospital. We can see the patient's the echocardiogram showed a gradually decreased of the systolic pulmonary artery pressure and gradually increasement in the left ventricle dimension. And this patient visit our clinic about 1 week ago, and fortunately, she stayed very stable clinical condition. So this patient is still in our close follow-up. So to summarize, PH is an uncommon yet potentially fatal disease in pregnant women, and PH is notified WHO class 4, which means extremely high risk of maternal mortality or severe morbidity. And the mortality of pregnant patients with PH is still high, despite more and more pH-targeted therapy in the recent years. The society guidelines advise against pregnancy and recommend considering termination if a PH woman becomes pregnant. And finally, a multidisciplinary decision-making approach regarding the optimal treatment options and alternatives to tetronic medications should be considered if the woman decides to continue with the pregnancy. Thank you. And this is my mentor, Professor Gu Hong, a very beautiful lady. And thank you very much.